And so I was going to cover a lot of information, but I'll go over it at a very overview. I've given the copy of the slides as well as the PDF format, so you're welcome to look at the information on your own. So, all right. So we'll start talking about now. How many of you are primary care or family practice type physicians? The majority, I imagine. Because as you know, the incidence of chronic kidney disease on the islands is very high. So I'll talk about chronic kidney disease. I'll talk about all the different things we look at in chronic kidney disease management. I'll talk a little bit about dialysis. I don't want to get too lost in the weeds with the dialysis issue. And then we'll talk about outpatient nephrology consultation. We're hoping to set up a program here where we'll have nephrologists on site and we can provide all the outpatient and inpatient care that you need. So, traditionally, I mean, I know when I started, we didn't talk about GFR. We just talked about creatinines when we talked about kidney function. And arbitrarily, you would say that a creatinine over 1.5 was high and you had chronic kidney disease. We've moved away from using creatinines and looking at GFRs, or glomerular filtration rate. And this is an old slide, but what it shows is the correlation between the creatinine that's measured and the actual kidney function. The physiological gold standard is something called the inulin clearance to measure the GFR, and that's considered the best research tool for GFR measurement. And what you can see is when you look at the actual measured creatinine versus the GFR, there's obviously a correlation. The higher the creatinine, the lower your GFR. But there's a lot of people out here that would have chronic kidney disease with the GFR less than 60, but the creatinine underestimates what their function is. And that's the reason that they moved away from the GFR, from the creatinine into the GFR. Now, what we used to do is something called MDRD, and I don't want to get too lost in the equation, but when you order a creatinine on a metabolic panel, it will give you a GFR. In the old system, it would tell you if African American, this was the GFR. If it's not African American, this is the GFR. That's because the equation that they used was something called the MDRD. The MDRD was a study that was done by the National Institutes of Health in the 80s. It was a modification of diet in renal disease. It was a study that first looked at protein restriction in kidney patients. But basically it looks at the creatinine, the age, the gender, and whether you're African American or not. And the reason they had that term in there was because as a race, African Americans had higher muscle mass than non-African Americans. So when they did the study, they included that in there. But most reference labs have gone away from the GFR calculation based on MDRD because of the race equation, and they use a different formula. Again, the formula itself doesn't matter, but it basically looks at the creatinine, the age, and the gender of the patient. There's no race consideration. And so when you get a creatinine, you'll get a GFR. If they're using the new way of doing this, there won't be two numbers based on the race. The important thing you need to know about these GFRs is the weight is not included in there. And so if you have someone that is obese, the calculated GFR will actually underestimate what their true renal function is, and vice versa. If you have someone that's a thin individual, the calculated GFR will overestimate what their true renal function is. Because technically the number that they give you in this formula is for someone who's about 70 kilos. So so you have to just factor that in when you think about GFRs. So the other thing I wanted to talk about, because this is very confusing to people, is how do you look at protein in the urine? Okay, as part of diabetes workup, obviously we measure urine protein. So you can check either the albumin, which is only the albumin in the urine, or the total protein, which includes the albumin plus the other proteins that you would have in the urine. So if you're talking about the albumin, it is 30 milligrams a day is normal. And then Over 30 milligrams up to about 300 is what they call microalbuminuria. And then over that is macroalbuminuria. If you're talking about total protein, it's 150 milligrams a day. Now, it doesn't really matter which one you order as long as you understand the differences between the two. What nephrologists will typically order is we'll order the total protein because if you're doing screening for a diabetic, a urine albumin is perfectly fine. But we're also looking for other things like myelomas, paraproteinemias, things like that. The thing that you do have to realize, though, is a urine albumin by itself doesn't mean anything. Okay? If you just get a urine protein of 300, it doesn't tell you anything because we're talking about a concentration. So if the urine is really concentrated, the urine protein number will be high. If the urine is really dilute, the urine protein will be low. So whenever you're interpreting a urine albumin or a urine protein, you always have to look at the ratio between the protein and the creatinine because that corrects for the concentration or dilution of the urine. So when we say, someone has a urine protein to creatinine ratio of 0.5, that means they're spilling about half a gram of protein a day. And as I said, normal is less than 150. But again, this depends on the size of person you are. The bigger you are, the more creatinine you're going to make in a day, and you will actually underestimate what their protein is. But when you think about urine protein, again, the things to remember is check the ratio, don't look at it by itself, and you can do the albumin or the protein, but there's different numbers based on which one you use. If you wanted to know, if you had someone that was really big and they had a creatinine clearance or they had a protein level of 0.5 on their ratio, if you wanted to know exactly how much protein they're spilling, you can do a 24-hour urine, which will tell you more specifically for that person. In practical considerations, it really doesn't matter. But you may have some patients, let's say, that have glomerulonephritis and you're treating them and you want to see what their response to therapy is, so you need to have a better idea. But for the most part, a random specimen is fine. So the stages of kidney disease, you're very familiar with this. So we consider CKD really 3 and below, 3 and above. So 30 to 59 is stage 3. And then you have 3A within that, which is 45 to 59. 3B is 30 to 44. And then you have 4 and 5. We talk about stage 1 and 2 if you have some other problem. Let's say you have protein in the urine or you have some type of structural kidney disease. Theoretically, you could consider them stage 1 and 2. But what we're talking about is practically 3 to 5. So I was going to just briefly touch on all the things that we look at in CKD management. Am I going too fast? Is this okay? All right. So when nephrologists see patients in clinic, some of the things that we're looking for obviously is blood pressure control, anemia, bone and mineral disease, phosphorus, those things. We'll talk about that briefly. Hyperkalemia, acidosis, and then dialysis and transplant. Now, the thing about blood pressure is the vast majority of people with chronic kidney disease will have high blood pressure, 85% usually. And it is probably the most important thing to decrease the rate of progression of chronic kidney disease. Now, the interesting thing about blood pressure in CKD is the goal blood pressure is not really clear. Nobody knows exactly what the best blood pressure is. When you look at the cardiac literature, clearly lower is better. But there is also renal perfusion that gets affected if your blood pressure is too low. As a general rule, in people that have proteinuria, lower blood pressure is probably better. In people that don't have proteinuria, lower blood pressure is not better and maybe could even be worse. So I think 130/80 is reasonable. ACE inhibitors, angiotensin receptor blockers are nephroprotective. Now, there's no reason to stop these medications in CKD as long as their potassium is normal. I've got patients with creatinines of 8 that are walking around on ACE inhibitors. As long as they're getting close monitoring, their potassium is fine, you can do it. The other thing that is probably underutilized, at least by primary care doctors, when it comes to blood pressure control and CKD, is diuretics. Okay, there is this perception that, well, you give diuretics if people have swelling, but in people with chronic kidney disease, you almost need a diuretic to control their blood pressure, even if they don't have swelling. So thiazides, they tend to lose effectiveness when your GFR gets really low. So in someone who's, GFR is 15 to 20, thiazides just tend not to be very effective, and a loop diuretic is better. Lasix, Bumex, torsemide. Spironolactone is actually a very effective blood pressure medicine in CKD patients. They don't have to have any hyperaldosteronism. It's actually a very effective medicine by itself, but it can obviously cause hyperkalemia if you're also on an ACE inhibitor. And the other thing that we'll see clinically is Lasix is not absorbed as well orally as Bumex and torsemide. So when you have someone who's really fluid overloaded and you've been giving them increasing doses of Lasix and they don't seem to respond to that very well, and they're still very edematous, and you're thinking about bringing them into the hospital to give them IV diuretics, a lot of times switching them to oral Bumex or torsemide can actually help them, because the bioavailability is better. The other thing about blood pressure is, I think, setting patient expectations. I mean, every one of you have patients that say, well, I'm on too many blood pressure medicines, okay? Now, there's a perception among patients that blood pressure is a one-drug disease, like hypothyroidism. You take one pill for it, or GI, PPI for a GERD, or you take a cholesterol medicine. But hypertension is not a one-drug disease. In fact, each medicine on average will lower your blood pressure 10 to 15 points. So if you're starting with someone who's got a blood pressure of 180, it's going to take 4 or 5 medicines to bring the blood pressure down. This is actually a slide that shows various blood pressure studies with the goal blood pressure in there. Some of them are in renal patients. MDRD was a renal trial. ASK was African American study of kidney disease. Renal and IDNT were the ARB trials in diabetics that showed a benefit to these medications. But the important thing about these studies is on average, it took 3 to 4 medications to bring their blood pressure under control. And these are done in academic centers by experienced hypertension nephrologists, specialists. And this is average. And if you're seeing a nephrologist for high blood pressure, your blood pressure is not average. I mean, there are patients out there on 1 or 2 blood pressure medicines. We just don't see them. So I think part of the issue is telling patients that we'll try to be judicious on the medications, use the best combination of pills, but we're not going to be able to, if somebody comes to me on 4 blood pressure medicines, I don't have any magic medicines you guys don't have access to that can just take them off all day and get their blood pressure under control. So I think a lot of it is really setting expectations that the important thing is to get their blood pressure controlled as opposed to the number of pills that they're on. So what are the medicines that have been shown to be protective in kidney disease? You're all familiar with ACE inhibitors, angiotensin receptor blockers. There's data for diabetic and non-diabetic patients with proteinuria. Technically, there isn't a lot of data in patients who don't have proteinuria who are non-diabetic. So if you have hypertension with no proteinuria and CKD, there's no strong data showing that these medicines have been beneficial, but we use them anyway. You're familiar with SGLT2 inhibitors, Farxiga, Jardiance. They've really come on strong the last few years. And they've actually they're showing a lot of benefits really across the spectrum of kidney disease. Diabetics, non-diabetics, proteinuria, no proteinuria. The latest one is Ozempic, semaglutide, which is really a diabetes medicine that's being used for weight loss. The European Renal Association meetings that were in Stockholm a few weeks ago, in end of May, they actually released data showing that there's actually outcomes that these medicines lower the progression of kidney disease, I think by about 25%. So that's going to be, and this seems to be irrespective of their diabetes benefit and their weight loss benefit. So that's another class of medications you can add to the mix. So there's a lot of medicines out there now that can slow down the progression of kidney disease. Uh, uh, are you guys familiar with the SGLT2 inhibitors, Farxiga, Jardiance? Okay. Just really briefly, they have a proven benefit. Um, when the things first came out, they said it was for diabetic patients with proteinuria, GFR over 30. But as it's been used more clinically, the benefit is not just in diabetics, it also helps non-diabetics, it helps people that don't have proteinuria, and we can actually use it a lot lower than the 30. You can actually use it down to dialysis if you're careful about it. There are a few things you need to know about these medications. One is the way they work is by pushing sugar through the kidney. So you have glucose in the urine because the medicines affect the way the glucose is handled in the kidney. So because you have sugar in the urine, you can get dehydrated. Like, diabetics, when they first present, when the sugars are sky high, it's because they're dumping all this sugar in the urine, they get super dehydrated. And so these patients, if you don't tell them about it, they will get dehydrated, the creatinine will go up. And this is a glucose diuresis. That extra sugar that's being pushed through the kidney is actually driving their extra water out. And so I never will start an ACE inhibitor and an SGLT2 inhibitor together. Because when you start someone with ACE inhibitors, the creatinine can go up, the potassium can go up. And then if they don't drink water and then you put both of those on together, then you can actually cause problems. And ultimately, this is a long-term protection issue. We're trying to protect these kidneys over the course of years. And so I'll start the ACE inhibitor, make sure they're doing well, make sure they're staying well hydrated, and then add the SGLT2 inhibitor later. And then there's an increased risk of UTIs because, again, there's sugar in the urine, so these patients have to void frequently, and they have to drink plenty of water. When these medicines first came out, there was a question about, does it have an increased amputation risk? It really hasn't panned out, but it's just something to think about. The biggest issue with these medications are the cost. I mean, they're several hundreds of dollars, which limits their cost. I was at the International Society of Nephrology meetings in Buenos Aires a few weeks ago, and I went around to all the representatives from different countries and asked them, hey, how much does this medicine cost where you are? And across the board, it was about $50 a month is what it costs outside the U.S. But here it's several $100s, and I think that's going to be the biggest issue with these medications. They work great. Like I said, the newest kid on the block for nephroprotection are the GLP-1 agonists, which are semaglutide, Ozempic. You hear about it in the news all the time. It's used for weight loss. It's used for diabetes, of course. The data was just presented a few weeks ago that showed that it has a specific benefit in slowing CKD progression. It can have a lot of GI side effects. It can cause nausea, vomiting. There's some more complicated stomach paralysis issues and stuff that have been reported with it. Again, cost is the biggest issue. There's a lot of people that are taking this for weight loss and paying for it privately, which is really restricting the access to the medication for people with diabetes and kidney disease. It's a little tricky to use in advanced CKD. I've got a patient that I see that, her GFR now is about 8, and she's very close to starting dialysis. She was on Ozempic, and for several months, she was having these nausea, vomiting, not wanting to eat. It was hard to tell how much of those symptoms were Ozempic versus just uremia. We took her off the Ozempic, and she's actually feeling better, so we're trying to push dialysis down further down the road. The other thing, of course, with all these medications, when you find a bunch of medicines that are individually shown to have a benefit in kidney disease, the question is, how do they all work together? We know that ACEs and ARBs work very well with the SGLT2 inhibitors because when they did those studies, they were comparing people that were already on the SGLT2 inhibitors. In the semaglutide study, which is called the FLOW trial, they didn't really compare them to SGLT and Ozempic. So we don't really know how all these medicines are gonna play together. Any questions about that so far? All right. Anemia, again, I'll just kind of run through these really quickly. Anemia is probably the single biggest cause of morbidity. People feeling tired, just no energy. And a lot of things go into it. Iron deficiency, of course, chronic inflammation. Erythropoietin is a hormone made by the kidneys, so when the kidneys don't work, there's no EPO. And we will work up anemia typically when your hemoglobin is less than 12, in CKD 3 to 5. Check iron stores. You may want to check a paraproteinemia workup, myeloma workup, obviously guaiac stools. We do not check erythropoietin levels. They're not useful. They don't really tell you anything. And you really should not, there's no need to do them. Our goal for anemia is a hemoglobin of 10 to 11. Okay, and we typically will target a transferrin saturation less over 20%. We don't really use ferritins because a lot of our patients have very high ferritin levels from chronic inflammation. So we tend to just use the TSAT and the hemoglobin. So when you have anemia, the first thing you do is you fix the iron deficiency problem. And if the iron deficiency is corrected and the hemoglobin doesn't come up, then you can use erythropoietin. Anemia of chronic kidney disease. You can give it orally or IV. Obviously, oral iron is a lot easier, it's cheaper, but it's very inefficient. For whatever reason, people with CKD don't absorb iron very well. So the iron levels don't come up. High incidence of constipation. These patients have a huge medication burden to begin with. They're already on 10, 15 medications that cause side effects. And so we have sort of moved away from oral iron as much as possible. There are multiple options for IV iron. There's ferrolicet, Venofer, Ferraheme. The dose is about a gram a day. That's what a gram at a time. And different IV formulations are different milligrams. So ferrolicet is 250 milligrams. So if you're going to give someone an iron load of ferrolicet, you have to give them 4 doses. Venofer is 200, so you give them 5 doses. Ferraheme is 510, so you give them 2 doses. We used to use iron dextran, which is a 1 gram dose, but there is an anaphylactic risk associated with the medication, and it can be pretty bad. So for the most part, we move away from that. But it is the cheapest iron out there, and you can give all of it at one time. So if you have someone who has difficulty getting to the clinic to get their iron infusions, you can do that. In our dialysis patients, they all get IV iron. I mean, hemo, obviously, you have access to the machine, so you can give the medicine through the treatment. But peritoneal, which is a home dialysis, we used to give them oral iron, but they had so much constipation. Now they come into the clinic for the routine appointments, and we give them intravenous iron just as a push over like 1 or 2 minutes. The other component of anemia in chronic kidney disease patients is EPO, erythropoietin. Now, when EPO first came out in the 1980s, that was the only option out there. So we would just say EPO. Now the term is ESAs because there's several different medications that fall into that category, medicines that stimulate erythropoiesis. So the original one was Procrit or Epogen, which is the exact same hormone that your kidneys make, the endogenous erythropoietin. There is a generic version of it that's come out pretty recently called Retacrit, which is a lot cheaper. Most hospitals are using Retacrit now, and in our chronic kidney disease patients, we use Retacrit. There's a modified version of EPO called Aranesp that probably came out about 15 years ago. They tweaked it to give it a longer half-life, so you could give it once a month as opposed to every couple of weeks, which is how you get Procrit. In practicality, it really hasn't held up. I mean, we can, so it's not used that often. There's a newer class of medications called Mircera, and I would say 80% of the dialysis patients get Mircera. So Mircera is actually not the hormone that EPO is. What Mircera is it's a medicine that activates the erythropoietin receptor. So it actually continuously stimulates the EPO receptor. And in dialysis, we like it because it keeps the hemoglobins a lot more stable. The problem in dialysis patients is they end up in the hospital, they get infections, whatever, their hemoglobin is just going up and down. And the range for dialysis is 10 to 11, which is a very narrow range to try to keep patients in. So most dialysis companies have moved away from EPO and are using Mircera. There's a newer class of medication called hypoxia-inducing factors that are all, some of these are pills actually you take for anemia. The data on that has been kind of mixed. The first couple that came out had some side effects and were pulled off the market. So not really sure how these are going to fit into the overall scheme of things. The thing that they are a medicine that you have to monitor very carefully. There's a black box warning increasing the risk of MIs, strokes. When they first did the EPO trials, they were targeting a hemoglobin of 13 to 14. And it doesn't make sense when you're using the hormone that's biologically identical to what your body makes and you're targeting a hemoglobin that's physiologically normal, why people would have a higher risk of clotting events. But it's very clear that the higher the hemoglobin is, the more cardiovascular problems you have. So the rate, it used to be 13 to 14 and then became 11 to 12, and now our target hemoglobin is 10 to 11. So you don't want to rapidly correct someone. If someone comes in, new diagnosis of chronic kidney disease, hemoglobin's 8, you really want to bring their hemoglobin up slowly because it can cause an increased risk of clotting events, and it can also cause severe blood pressure elevations when you give the EPO too much too fast. We typically will start therapy when the hemoglobin is 9.5. The goal is 10 to 11. And EPO is the signal that tells your bone marrow to make blood. If your bone marrow doesn't have the raw materials like the iron, the EPO is not going to do anything. So you always fix the iron deficiency before you start the EPO. And what we typically will do is we'll check the hemoglobin level before each dose. You just poke their finger, make sure they're in range, and you hold the dose if the hemoglobin is greater than 11. And because of this black box warning, we've gone away from patient self-administration. Years ago, we used to just give them a prescription. They would just poke themselves, give themselves a shot like they give insulin. But because of the risk, you should always have them come into a clinic, check their hemoglobin, make sure it's in the safe range, and then give it to them. On the anemia? You guys are an easy crowd. I like this. All right. The next big area that we focus is bone and mineral disease. And there's a lot of mineral bone problems that can happen in kidney patients. They can get low calciums, high phosphoruses, vitamin D deficiencies, and an elevation in their parathyroid hormone as a result of all these other problems. So we'll monitor their intact PTH and their calcium, etc. The word intact PTH, that's what when you guys order a parathyroid hormone, you see an intact PTH. Do you know why that is, why it's called intact? It turned out that years ago, we would just check a parathyroid hormone level. But then when the PTH is broken down naturally, all the fragments of the PTH were measured by the assay in CKD patients. So the PTHs were running really high. And so now they had to develop an assay just to look at the intact molecule, the whole molecule. That's why it's called intact PTH. There's no other reason than that. So again, the treatment depends on what the problem is. If you have vitamin D deficiency, then you would just give them over-the-counter vitamin D3 or ergocalciferol, which is D2, and that's a prescription. If they have a high phosphorus, you'll put them on a low phosphorus diet. You'll give phosphate binders, and there's a new medicine that's come out for that. If they have high PTH levels, you will typically give them vitamin D analogs like calcitriol. There's a few other ones. And these other medicines called calcium mimetics. And if someone has a low calcium, they just need some oral calcium, typically Tums. And I'll go over these real briefly. So when you have a high phosphorus level, what we do is we give you phosphate binders. And what a binder is a medicine you take with your meal. It binds up the phosphorus in your stomach, and it prevents you from absorbing it. Okay, and there's different kinds of phosphate binders. There's a calcium base, which are Tums, which is calcium carbonate. Phoslo is calcium acetate. They're cheap. There's non-calcium based binders. So something besides calcium is being used to bind up the phosphorus in your system. There's Renvela, Fosrenol, there's a whole list of them. Aluminum is probably the most effective phosphate binder there is. It brings your phosphorus down better than anything else. but it can cause the aluminum accumulation has been associated with dementia in dialysis patients. So you can use it short term. Let's say somebody comes in with rhabdomyolysis, the phosphorus is 15 from their muscle injury. You can use aluminum, but you can't use it otherwise. A medicine that just came out a couple of months ago is something called tenapanor. It is completely different than a phosphate binder. A phosphate binder just literally soaks up the phosphorus and prevents you from absorbing it. This medicine actually blocks the pathway that phosphorus uses to be absorbed. So it's irrespective of the diet, and it's one pill twice a day because it's not related to the diet. It actually blocks the mechanism itself. When you're talking about calcium binders or non-calcium binders, you're talking about patients typically will take 3 to 5 with each meal and 1 to 2 with snacks. So they're taking 20 pills of these binders. This new medicine is 1 pill twice a day. Diarrhea is a major side effect, so you got to be really careful using it. But I think this medicine is going to revolutionize phosphorus management. Medicine you can use are calcimimetics to bring someone's PTH down. It's indicated for secondary hyperparathyroidism, meaning a high PTH associated with kidney disease. Now, the way these medicines work is they bind to the calcium sensing receptor of the parathyroid gland, and is very effective at lowering PTH. A normal PTH is around 50, 60 is sort of the upper end of the normal range. When you have someone with primary hyperparathyroidism, they're typically going to have a PTH of 150, 200. In dialysis patients, the PTH can go into the thousands, 5,000, 10,000 is not uncommon for dialysis patients. Parathyroidectomy is what we historically used to do. And the problem with parathyroidectomies in these patients is the patients that get PTH problems are the non-compliant ones. They won't take their binders 3 times a day. That's what drives their PTH up. When you take the parathyroids out, the calcium will plummet. I mean, I've had patients that have had to take 100 Tums a day just to keep their calcium of over 6. So you're treating a problem where they won't take 20 pills a day with a surgery that they have to take 100 pills a day, and you know how that's going to end. So we've moved away from parathyroid surgeries on these patients, and really these medicines like Sensipar work really well. They can cause GI side effects and hypocalcemia. There's 2 options. There's Sensipar, which is the oral version, and there's an IV version we use in dialysis. The IV version causes a lot more calcium problems, so we don't use it that often. Now, theoretically, you can use this medicine for someone with primary hyperparathyroidism. If you have someone who's got a PTH that's high, kidney stones, hypercalcemia, they have a parathyroid hyperplasia, but they're not a surgical candidate, they're not going to tolerate parathyroid surgery, you can use these medications to treat them medically. And I've done that a few times over the years as well. Just a word about osteoporosis, because you guys treat a lot of osteoporosis, and there's a relationship between osteoporosis and CKD's bone disease. The bone disease you see in kidney patients is renal osteodystrophy, okay? And so it's really hard to know how to manage osteoporosis in this patient population. The textbooks, at least 20 years ago, said, well, you should do a bone biopsy, and then if the bone biopsy shows osteoporosis, then you treat them for osteoporosis. If the bone biopsy shows osteodystrophy, you don't treat them. In 20 years, I've never talked to a patient about it, and no one will agree to it anyway. So in all of these studies, they exclude dialysis patients and CKD patients. Every single osteoporosis study that's ever been done, CKD is excluded because of that confounding factor with osteodystrophy. What we've done in osteoporosis patients that are high-risk patients, we'll use bisphosphonates typically at a lower dose, maybe half the dose, and you monitor their PTH and calcium. We've seen a lot of people on Prolia that have had profound hypocalcemia. I mean, months and months of them having to come in to get IV calcium in the infusion center 2 to 3 times a week. So it can cause profound hypocalcemia. So it's you got to be a little careful if you're going to use in CKD patients. We typically won't give calcium and vitamin D routinely in someone with osteopenia. If they have low calciums or low vitamin Ds, we'll give it. There is this controversial area as to whether giving oral calcium can cause increased vascular calcification in these patients. And that's one of the reasons they've moved away from non-calcium, from calcium binders to non-calcium binders. Just a quick thing about hyperkalemia. You tend to see it in diabetics and in later stage CKD. There are some kidney diseases, like polycystic kidney disease is an example, that they almost never will get hypotassiums even when the creatinine's 10. Medications exacerbated, ACEs, aldosterone blockers, and Entresto. Treatment, you can do low potassium diet, loop diuretics, obviously back off on some of these medications that they're on. And then there are these potassium binders. A potassium binder just binds up the phosphorus that's in the gut. The potassium that's in the gut prevents you from absorbing it. Veltassa and Localma are the new ones. Kexalate is the one that we've used for many years. Kexalate is a exchange resin, so it is sodium potassium exchanger. So it basically absorbs potassium, releases sodium. So you can actually get a sodium load from kexalate that can cause hypervolemia. Metabolic acidosis, we see that in advanced CKD, and typically 4 or 5s. Diabetics are more prone to get this. The reason we treat metabolic acidosis is that it can cause increased bone resorption because your body tries to correct this acidosis, and it can cause osteopenia long term. Goal is keeping their bicarb 20 or greater, okay? And so you can either give them oral bicarbonate tablets, which is sodium bicarbonate, 325 milligrams or 650 milligrams, or there's sodium citrate. Sodium citrate is a liquid. It tastes kind of gross. It's very salty. But sometimes people will put that on their food because they can't take regular salt, and you can get people to take it. But either of those are options. A few other medication considerations in CKD patients. Some drugs you need to avoid. NSAIDs, obviously, because of their nephrotoxic effect. Metformin is, once the GFR gets to 30 to 40, you're pushing it, okay? The old recommendation from metformin was a GFR of 55. You had to stop the medication. But there's been more use of metformin in lower CKDs that as long as you have someone with stable kidney function and they have close follow-up, you can continue to use it. But now there's so many more medicines that are out there for diabetes that actually have a nephroprotective effect. So you're seeing a lot of these metformin being pulled earlier. The other thing is, phosphorus enemas, Fleet's enemas. I mean, I've seen patients who've had, a colonoscopy or something, and it shoots up their phosphorus to 15 to 20 with one enema. It can actually be fatal in dialysis patients. A lot of medications you can use, but they just need a dose adjustment. Antibiotics are common. Gabapentin is notorious for causing accumulation. Acyclovir toxicity is very common in kidney patients. PPIs is like Prilosec is an evolving field. There are clear examples of allergic interstitial nephritis and acute kidney injury you can get from these medications. It's, we'll see that a few times a year, but it's pretty rare when you consider the number of people that are taking the medication. There is, however, this population link between CKD and PPI use. When they look at population studies, people that are on PPIs tend to have a higher degree of CKD compared to people that don't have CKD that are on PPIs. But this is the link. It really hasn't been studied. So what I tell patients is, look, if you really need it for symptom control or for a medical issue like Barrett's or whatever the case might be, take it. But if you can get away with H2 blockers like Pepcid, you're better off doing that. When you get into advanced CKD, like creatinines are pushing 4s, 5s, ideally we should just muck around with all these medications, diuretics, ACE inhibitors, because when you change one thing, it can have effect on other things, and so our preference is to manage these. Just a few words about dialysis. If I got another 5-10 minutes, I'll be done. The first thing about dialysis is it's a quality of life issue. It's not for everybody. And so you really, I think the first thing is to take a step back and say, are you really going to make this person's quality of life better by doing dialysis? And if the answer is no, you're probably better off looking at palliative care. The other thing that you come across practically is if you have a family member or a close friend that's on dialysis, the patients are going to have 10 times the fear and the anxiety. Okay, but every person is a little different, and so an individual's experience on dialysis may not be the same as their family members that didn't take care of themselves as well. There are several dialysis options. You can do in-center dialysis, where you go into a clinic 3 times a week, which is what's offered here. You can do peritoneal dialysis, which in case you don't know, I'll show you what that looks like. You can do home hemodialysis, using dialysis, cleaning the blood, but you're doing it at home, and then obviously kidney transplants. You want to avoid PICC lines in CKD patients. A single PICC line can cause a 20% risk of subclavian stenosis. And if you have a stenosis in your subclavian, that entire arm is shot for a fistula or graft. You can never put one in again because your arm balloons up. And then when patients are nearing dialysis, we'll tell them to preserve their non-dominant arm. So if they're right-handed, we'll say, hey, save your left hand. Don't let anybody do any blood draws or blood pressures in that arm, because you want to keep the veins healthy, so when the surgeon goes in and does the fistula, it's going to work the best. Ideally, you want to give yourself 6 to 12 months for a fistula, and a graft is 2 to 4 weeks. I'll explain what these are just to make sure you guys are on the same page. So a fistula is a connection between an artery and a vein, and it's a direct anastomosis. There's no artificial material, no prosthesis, anything in there. So you can take the radial artery connected to the cephalic vein, which is here at the wrist, and that's called a seminofistula or a radiocephalic fistula, or you can connect the brachial artery to the cephalic vein in the upper arm, but that's a direct connection. The advantages of a fistula is that there's no prosthesis, so there's a much lower risk of clotting. It stays open for a long time. I had a patient one time that got a kidney transplant, and the transplant lasted for 25 years. And at the end, his kidney failed. His fistula was still going. We just hooked him up. And so some of these fistulas can last for decades, and you couldn't clot them if you wanted to. Okay. The downside to a fistula is it takes a long time to mature, because what you're doing is you're taking the artery, you're plugging it into the vein, and then the pressure head of the artery is feeding the vein and is getting the vein stronger, and then you're putting the needles into the vein. So if you have small veins to begin with, you have diabetics with vascular disease, a lot of times the fistulas don't mature. It's called primary failure. They don't mature to the point you can use them reliably. That's why you need to give time for these to work. There is a newer technology called ellipsis. Medtronic makes this. It's a percutaneous fistula, where what they do is they cannulate the vein, and then they basically puncture the artery through the vein and pull out and anastomose the two of them together. So it's a pretty cool technique. The data, we still don't know how it's going to hold up long term, but that's usually done up here. It's kind of in between the two fistulas that we have. But the fistulas are the way to go if the patient's anatomy will support it. The other thing you can do is called a graft. So a graft is still a connection between the artery and the vein. The difference is you have a prosthetic piece of material that connects the two. So you can either do a straight graft where you connect the graft between the artery and the vein, or you can have a loop graft where you connect the artery and the vein. And loop grafts are typically in your forearm. So you'll see a U-shaped graft. The advantage of a graft is you can use it 1 to 2 weeks after you put it in. You're not waiting for the vein to mature and get stronger and thicker before you use it. You just want the swelling to go down. The downside to a graft is that it can clot more because it's a prosthetic material, and it can also get a higher infection rate. But when you're comparing a catheter, a dialysis catheter, to a graft, a graft is way better. So fistula is better than a graft is better than a catheter. Now with these catheters, and you guys are familiar with regular central lines where they just put in the IJ, a hemodialysis catheter goes in the same place in the IJ, but instead of it coming straight out, they tunnel it under the skin and it comes out on your upper chest. So they call it a tunnel dialysis catheter. The tip of it is typically in the right atrium. They put those catheters in a little bit deeper because you need a higher blood flow with the dialysis and you don't want to kind of suck it up against the SVC. The other thing about a dialysis catheter is it has a little cuff, which is a little bit of Velcro that is in the chest. So you can't just pull those out because that after a few weeks, that cuff kind of blends into the tissues. So you actually have to dissect it out to remove the catheter. The advantage of a hemodialysis catheter is that as soon as you put it in, you verify placement, you can use it. It's tunneled under the skin, so it's more comfortable for the patients. The infection risk is a little bit lower because it doesn't just pop in. It just there's a longer path the bacteria have to take. You can leave them in for weeks to months, but they will get infected. It's not a question of if, it's a question of when. And patients love it because, the nice thing about patients, they don't have to be poked with the needle. And the other thing is, after the dialysis treatment, they don't have to sit there and wait for 20 minutes for the to hold pressure. But it's a terrible thing medically for these patients because their infection rate is high. The other problem with these catheters is it doesn't give you efficient dialysis. A fistula and a graft will give you much better dialysis. So if you're talking about a bigger person, you may need 5 hours of dialysis time on a catheter to get them adequate dialysis, whereas if you had a fistula or a graft, they could go to 4 hours. So you want to try to minimize these as much as possible, but they are a necessary evil because you can put them in and use them right away. Now, one of the things we'd love to do over here is to develop a robust home dialysis program because that really is the better way to go. Patients love home dialysis. They feel so much better. They have much more independence. They're able to do a lot more. So the majority of dialysis patients go to a clinic and they have a time, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, and usually it's 4 hours, 4 to 5, I would say. But home dialysis has multiple advantages over in-center. And there's two options for home dialysis. You can do peritoneal dialysis, in which you're using your abdominal cavity, your peritoneum, as the filter that moves stuff in and out. Or you can do the same hemodialysis that they do in the clinic. You can do it at home with simpler machines. So for peritoneal dialysis, it's very simple. They put a catheter in the belly, and then there's a tube sticking out, and then you have these bags of fluid, and then you basically put the fluid in, it equilibrates, gets all the toxins out, you drain the fluid. And you can do it manually. You can just hang a bag on a pole, do an exchange. It takes about 15, 20 minutes, unplug everything, go about your business. And you can do that 3 to 4 times a day. But the vast majority of people use what's called a cycler. And you do it at nighttime. So what you do is you take 2 bags and you put that on the machine. And then you program the machine to put 2 liters in, leave it in for an hour and a half, drain it out. And so you can do that at night while you're sleeping. Okay? So it opens up your day quite a bit. And the other thing is people feel a lot better because the way that, the paradoxical thing about dialysis is the more frequently you do it, the better you feel. Because that's what the kidneys do. The kidneys are constantly removing toxins a little bit each day. When people get home the 3 times a week dialysis, they feel really washed out and wiped out. After dialysis, the rest of the day is gone, and then the next day they feel a little bit better, and then the day after they actually feel pretty good, but then they have to go through and repeat the cycle again. But on home dialysis, people feel so much better. In fact, if you have a home patient and you have to put them on 3 times a week for some reason, maybe they have infections, hernias, whatever the case might be, they're kicking and screaming because they don't want to come off home dialysis. People feel so much better on this. And really, you should have 20 to 30% of home patients is the way to go. The other thing is you can do home hemodialysis. So the same blood dialysis that you do in the clinic, you can do at home. Now, I don't know if you guys have seen a regular dialysis machine, but it's a pretty big, complicated machine. These are very simple machines that they have, and there's a next stage, and that little thing at the bottom is actually the water. It makes the dialysis solution, and you can make 60 liters of dialysate, and the dialysis machine itself is at the top. And then the other one is Tableau. Tableau is the new kid on the block, and it's frankly a much better machine for home hemo than next stage. Tableau, the entire water purification system is in the machine itself at the bottom. So that machine just plugs into a regular electrical outlet, and it plugs into any faucet, and you can get dialysis quality water all built into that machine. And it's easy. It's basically a touch screen. It tells you exactly what to do. The training time on next stage is about 6 weeks. The training time on Tableau is about 2 weeks, less than 2 weeks for a patient. And these are patients that have no experience whatsoever doing dialysis. They can learn this machine in 2 weeks. But patients probably feel the best on home hemo even compared to PD. But this machine really has revolutionized home dialysis. In the vast majority of patients, transplant's better than dialysis. Not always, okay? The bottom line about dialysis versus transplant is, if everything goes well, it's great. If everything doesn't go well, transplant can just be a disaster. So, every center has its own criteria. There's some basic things that they have in terms of cardiac evaluation, psychological evaluation, all these things. But every center is a little bit different. You can either do a cadaveric donor, so a donor that is someone who died in a car accident that donates their organs, or you can do a living donor, so you either get a kidney from someone, a friend, a family member. They're also doing these paired donations. So let's say you're on dialysis, you have a family member that wants to donate to you, but they're not a match. But there's another pair where the donor and the recipient are not a match. They will do sort of a crossways. So his donor will give to you, and your donor will give to him. So they're doing a lot of paired donations that have really increased the number of transplants. And on average, a kidney transplant will last you 15 to 20 years if you take care of it. They're actually really good therapies for long-term dialysis patients. But obviously, compliance is critically important. You've got to take the rejection medicines, and you have to be religious about it. If you skip them, you can take years off the kidney, and you can have to get acute rejection. There is an increased risk of malignancies and infections in some of the patients. So just a couple of words about diet. Low sodium, low cholesterol, of course. Diabetic diet as appropriate. All patients with chronic kidney disease don't need a potassium or a phosphorus restriction. If the potassium and phosphorus are normal, just leave it alone. And protein restriction is very controversial. Okay, is more clearly excessive protein is not good. Dramatically restricting your protein is not good. There's been a lot of conversations about plant versus animal proteins. The bottom line is, almost every patient that starts dialysis is malnourished. And if you look at all of the negative predictors of mortality in dialysis patients, low albumin is by far the biggest predictor of mortality in these patients. So what we generally will tell our patients is, don't go out of your way to eat protein, don't go out of your way to avoid protein, but you really should do sort of a 60 to 80 gram protein diet. And we actually put the majority of our patients on protein supplements because in their diet, just with all their restrictions and their appetite, they don't tend to do that. And dietary consults can be very confusing and very useful because they're trying to manage a diabetic diet with the high blood pressure, cholesterol, everything else. Another thing I wanted to point out is people underestimate cardiac disease in the dialysis population. Okay. By the way, you guys have all these slides, so you're welcome to distribute it amongst yourself. What this shows, this is old data, but it actually shows the mortality from cardiac disease in dialysis patients, the red at the top, and the yellow, which is the general population. Now, obviously, as you get older, your cardiac disease goes up. So, you can see that male, female, African American, non-African American, the risk goes up. But you can see that the dialysis patients have a much higher risk than non-dialysis patients. And the other thing I would say is this is a logarithmic scale. So from here to here is 10-fold, from here to here is 100-fold, from here to here is 1,000-fold risk. And to put that in perspective, when you talk about the risk of smoking and lung cancer, that's about 10. But if you look at a dialysis patient who's, let's say, 25 years old, their risk compared to an age-matched control is 1,000-fold. And we're not talking about a diabetic necessarily. This could be someone with a genetic disease, or it could be somebody with a IgA nephropathy or polycystic, whatever the case might be, that has no intrinsic cardiac disease. But there's something about ESRD and the dialysis that dramatically increases cardiovascular risk. So you never want to blow off cardiac symptoms in a dialysis patient, regardless of how young they are. So if you're if you're a 25-year-old dialysis patient, your risk is 1,000 times higher than an age-matched control, and your risk is the same as an 85-year-old non-dialysis patient from a cardiac standpoint. I want to finish up by saying, what kind of patients should you refer to nephrology? So, we obviously don't need to see every single CKD patient out there. 4 and 5s or 3s that have significant proteinuria. Okay, when they say moderate, they're usually talking about the microalbuminuria range for 3Bs and macroalbuminuria over 300 milligrams for the 3As. The other thing is when you see a young patient with proteinuria, especially as you see a young guy, a guy in his 20s, there's genetic diseases like Alports and things that can pop up. Or if you see proteinuria in a non-diabetic with a normal GFR, because a lot of times those guys actually have a glomerulonephritis. It's not really something else. And if you just let that smolder in the kidneys, eventually their creatinine is going to be 4, and you do a kidney biopsy and you've lost the window to treat. And one of the things they talk about in CKD is this heat map. So the high risk and the very high risk patients. So you have the different stages of CKD here. You have the different degrees of proteinuria there. It makes sense that the worse your kidney function is, the higher risk of progression. And the more proteinuria you have, the higher risk of progression. And the more proteinuria you have, the earlier you want to refer those patients, because, as I said, we do have a lot of medicines in our tool chest that we didn't have before to slow the kidneys down. Because ultimately, what we're trying to do is to prevent these patients from going on dialysis. The average life expectancy of a dialysis patient is 4 to 5 years. So for the vast majority of cancers, if you were diagnosed with dialysis and cancer on the same day, you would die of dialysis-related complications than cancer-related complications. It's a high morbid state, and so that's why trying to prevent these patients from getting other. They've seen urologists, they've had all these stone extractions. We actually will go and try to figure out why they're forming stones and try to be more preventive from causing stone formation. Obviously, genetic renal diseases, polycystic, Alports, I don't want to get into that, but there's medications out there that you can use for that. So what are the opportunities to really, improve kidney care? Well, for dialysis patients, really more engaged care helps. If you see these patients every week, you're dealing with small problems before they become big problems, you're preventing hospitalizations, that really is help. So ideally, you could have a situation where the standard of care is 4 times a month. Weekly dialysis patients are seen by their nephrologist or a advanced provider. And also developing protocols, anemia management, phosphorus management, all of these things. I think proactive ESRD care makes a huge difference. A CKD clinic. I mean, you don't want to wait till someone crashes into dialysis. What's amazing is if someone starts dialysis in the hospital, AKI or progression of CKD, in all comers, sepsis, whatever, 80% of those patients are dead in a year. Okay, I mean, the mortality of someone starting dialysis in the hospital is extremely high. So what you really want to do is have a CKD clinic, do education, get these people into home dialysis, get these people transplanted, risk factor modification, delay dialysis as long as we can. And then also inpatient coverage. There's a lot of patients that we can help you with. Somebody comes in with CHF and CKD, which you guys probably half the patients you guys have with CHF probably have some degree of CKD. Managing their diuretics, getting them plugged into the system, establishing a robust home dialysis program. But there's also a huge need for community awareness, the things that you can do to really help patients understand lifestyle choices, things that they can do to prevent them from going on dialysis. And then, so last thing, to summarize, the GFR has replaced the creatinine to monitor renal function. There's various aspects involved in CKD management. Home dialysis is a great option for these patients, and proactive CKD management can delay the progression to ESRD and improve the mortality of these patients. So.